Professor Stone spoke earlier, and it's an absolute pleasure to have him here. No, I don't want you running, mate. You know, I've heard about the age of the osteoporosis service, and
yeah, I'll see you after. Right. Yeah, I'm going to talk about treatment sequence. By way of introduction, yeah, we have some updated guidelines, and they have repositioned the use of, in particular, anabolic treatment. So that's what I wanted to focus on. So first of all, we have the update to the NOG guidelines, the National Osteoporosis Guidelines Group, and they are the de facto osteoporosis guidelines for England and Wales now, because all the nice stuff is so out of date, apart from the updated guidance for romosozumab, which I'll tell you about. I mean, the last time NICE looked at teriparatide was 2008. It's obviously a nonsense to still be referring to that, but it appears in the NOG guidelines. And of course, the osteoporosis treatments we're going to look at, the two categories, are anti-resorptives, bisphosphonates, denosumab, and the two anabolics that we use at the moment, teriparatide and romosozumab. So why do we treat patients? Well, that's to improve bone strength and reduce fracture risk. Anti-resorptives, of course, reduce both bone resorption and formation, but that limits their effect, in particular with respect to restoring bone architecture, whereas bone-building treatments, or anabolic treatments, can partially restore bone architecture. They have a bigger and faster effect on bone density. You've already heard about that from Kasim earlier. And that results in superiority in terms of reducing fracture risk versus bisphosphonates. So that applies to teriparatide and romosozumab, and we have two trials, randomized trials, to kind of prove that, and I'll show you the results of those studies. So the update in NOG, which goes hand in hand with FRAX, the fracture prediction tool, is that we should now consider bone-forming anabolic drug treatments as a first-line treatment in those at very high fracture risk. So there's this new category of very high fracture risk. So we're all familiar with high fracture risk. You know, it's in the red zone you treat, but there's this new category of very high fracture risk. And that statement particularly applies to people with vertebral fractures, and we've very appropriately heard quite a lot about vertebral fractures today. So this is the FRAX-NOG intervention graph telling you whether to treat your patient or not. And you can see you've got the new category right at the top, the darker red. And if you fall on that, you're at very high risk. Then it will indicate to you that you should consider the use of an anabolic treatment. And you should consider using it as a first-line treatment. I should also tell you that there have been updates to FRAX. So if you're trying to identify people at very high risk of fracture, you want to incorporate all the relevant risk factors. And there are some updates to FRAX which incorporate additional risk factors, and perhaps the most, one of the more important ones, of course, is falls. If you're falling a lot, you're going to be more likely to fracture. And there are arithmetical adjustments available in the NOG guidelines to let you adjust the risks according to these various risk factors. So recurrent falls is a 30% increased risk of major osteoporotic fractures. Discordant lumbar spine versus hip spine. Your lumbar spine's low, but your hip spine's not too bad. There's an adjustment for that. Prednisolone dose you have to put into something called FRAX Plus. But unfortunately, FRAX Plus you have to register for, and there's a fee per patient to use that. And is anybody using FRAX Plus? No. Okay. And diabetes, you can tick the rheumatoid arthritis checkbox. For recent fracture, and Kasim's told you all about imminent risk of fracture, there's a big uplift to fracture probabilities. But that's only available in fracture. Woo! Oh, yeah. Yeah, so that was planned. That was... So if anybody was asleep, so that results in a marked uplift to fracture probabilities. But you're going to need Frax plus to that. But we'll come back to imminent risk of fracture. And for vertebral fractures, I think there's a strong argument for using anabolic treatments first, kind of across the board. The evidence is so strong that it's better to use anabolics under those circumstances. Now, to come to treatment sequence, if you pre-treat someone with anti-resorptives, that can reduce, and usually does reduce, the effect of a subsequent anabolic on bone density, especially at the hip. And that affects teriparatide more than romosozumab, but it does modify the response to an anabolic. So, the recommended standard practice is to use an anabolic first, if at all possible, and then after that, you use an anti-resorptive as a follow-on treatment. So that would preserve the anabolic effect on bone, and you would also get a further enhancement of bone density, particularly if you use denosumab, and I'll return to that. So teriparatide is a bone-forming treatment. It's been around for 20 years, so it's bone building. It's very effective for vertebral fractures, and the best treatment for people on steroids. It addresses the underlying pathophysiology. Daily injection, you use it for severe osteoporosis. The big news here, of course, is it's now biosimilars available, so there's been a 70% reduction in cost. This is the head-to-head trial. So this is risedronate, oral bisphosphonate versus teriparatide over 2 years, confirming that teriparatide is a superior treatment. So you get a 50% rate of vertebral fractures and non-vertebral fractures for those receiving teriparatide versus risedronate. So head-to-head trial confirming superiority. And that underpins these recommendations. So from NOG and sign of the Scottish guidelines, both gone for first-line treatment option of teriparatide in the context of vertebral fractures. And in NOG, we also say consider use first line if you're in that very high-risk group on the Frax score. And that's just to remind you that teriparatide is a very good treatment for your patients on steroids who have severe osteoporosis or fractures. You get a bigger rise in bone density. This is head-to-head versus alendronate, and a reduction in vertebral fracture rates. However, once you've treated with an anabolic agent, you do need to use follow-on treatment. And why is that? Well, on the left-hand side, you can see what happens if you don't give a follow-on treatment. So your bone densities will begin, if you look at the top two curves, your bone densities will drop if you give nothing. And on the right-hand side, you can see someone who's been treated with teriparatide and then given sequential bisphosphonates, follow-on bisphosphonates. And you see some preservation and some further improvement in bone strength. So you need to give follow-on treatments after teriparatide and indeed romosozumab. So moving on to romosozumab. So we have nice recommendations for the use of romosozumab, and that is nice position romosozumab as something that you consider as a treatment option for treating severe osteoporosis, postmenopausal women. It is limited, the license, to postmenopausal women who are at high risk of fracture, but only in the context of a major osteoporotic fracture within the last 2 years. So that's that imminent risk of fracture business. So under those circumstances, romosozumab is a treatment option. It has a dual mode mechanism of action, so it both stimulates bone formation as well as reducing bone resorption. So you get really big rises in bone density. And these are the biggest improvements in bone density that we've seen with any treatment in the history of osteoporosis. Here's the head-to-head trial versus alendronate. So this is 1 year. It's 1 year of monthly romosozumab versus alendronate, and then both groups get alendronate in the second and third years. And you can see pretty much a 50% lower rate of vertebral fractures in those getting romosozumab versus an active treatment. And importantly, you also see a significant reduction in the rate of hip fractures for those getting romosozumab versus kind of standard treatment with alendronate. So on the basis of that, romosozumab is a first-line treatment option in those at high risk of fracture and a major osteoporotic fracture within the last 2 years. In other words, that imminent risk of fracture group. So that's nice. In Llandough, we went a bit further and gave some, and together with the Royal Osteoporosis Society, produced a position statement and went a bit further and said, you know, if your bone densities are really low, T-score minus 3.5, or not so low, but you've also got fractures or you're very high fracture risk, these are other groups of patients where you consider the use of romosozumab. Again, like teriparatide, you're going to need follow-on treatment with an anti-resorptive, because if you don't, and this is what happens, these are the phase 2 trials, so it was 2 years of Romo followed by nothing. Bone densities fall off quite rapidly if you do nothing. So you give a follow-on treatment. And in this trial, the follow-on treatment was alendronate. If you look at the blue curves, you see preservation of the bone densities. But if you follow on with denosumab, and that is our default treatment to follow on after romosozumab, you actually see a progressive further rise in bone strength, bone densities after romosozumab. So we would often choose denosumab after treating a patient with romosozumab. A few words about denosumab in passing. I mean, it's quick and easy to give. It's a subcut injection. You do need to give it long term. It can be given at home. So we have a very successful self-injection program, and we have 500 patients in that. We're hoping to expand that. And of course, it's not nephrotoxic, and Anthony's already talked about zeledronate. The other point to make is, if you treat with denosumab, bone densities carry on going up year on year, kind of forever, but we've certainly got data out to 10 years. So on the left-hand side, you can see bone densities steadily improving with long-term denosumab. On the right-hand side, you've got 6 doses of zeledronate. So it goes up, but then it plateaus. So you get bigger rises in bone density and bigger reductions in fracture risk. And we now have a sort of real-world study. This is a USA Medicare program, so Health Management Organization data, looking at fracture rates, comparing those getting denosumab and zeledronate, and the fracture rates are looking lower in those receiving denosumab versus zeledronate. So the higher the risk of fracture, the more likely we are to go for both anabolics and then denosumab. So in summary, we've got new NOG guidelines, we've got FRAX updates, I've shown you that, we've got a good range of effective treatments. Anabolics can now be considered for first-line treatment for those at very high risk of fracture or imminent risk of fracture. We talked about teriparatide, and we've talked about romosozumab. Thank you very much for listening.